Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
Welcome back to Pod Patrol. It's episode 2 with Dr. Jeff Dikis
and Dr. Leland Jaffe.
If you joined us for episode 1, you kind of got the backstory about who we are and what we do. We figured we'd dive a little deeper into our jobs and our roles and our current day-to-day jobs. So Leland, you are the clerkship director for your school. So what does that actually entail?
Sure. So, this was a role I took over, I would say, a little over 2 years ago. Put on my administrative hat when I took over this role because it was a much different workload in terms of my typical week. So basically what I do is I run the clerkship and residency placement office at the college. And my main role is to make sure that, number one, the students get placed effectively into their elective rotations. So those are their clerkships that they choose to go to across the United States, really, from coast to coast.
So fourth year.
And then, they actually go the second half of their third academic year into their fourth year.
Okay.
And then coming up soon, match week is coming up in March here. So we help to navigate the residency interview and application process and to work to get our students placed into residencies. So we just came off of interviews last month down in Frisco, Texas, for a nice little shout out to Frisco. In fact, our last year in Frisco. So, we're moving interviews up to Chicago next year. So a little bit eeasier commute for me.
That'll be a lot easier for you.
Yeah, a lot easier. And then next month is our match. And we overlap a lot in terms of the allopathic and osteopathic match. Similar time of year, similar process. In fact, the software that Podiatry uses now to conduct the match is identical to allopathic medicine as well, too.
So let's take a peek behind the curtain. So let's say that I'm a student of whatever year, and I'm working towards this process because it seems intimidating. I work so hard as a student. I learn, I take all these exams, but the payoff, at least the initial payoff, is getting the residency that I want. Right? Every student wants to work towards the residency that they want. Now, that may end up being the actual residency that they had their heart set on, or they may visit and end up with a completely different set of ideals or a place that they end up wanting to go. But let's say I have completed my fourth year and I have selected the programs that I would like to rank. Can you kind of walk through that process?
Sure. So each student is given a certain amount of electives. And again, those are hospitals that they choose to go to. After they complete their elective, then the students, as well as the residency themselves, have a general idea of whether they're compatible or not. Because all the residencies are very similar in many ways, but there also are differences, right? Some are community hospitals, some are much smaller, some are more rural, some are urban. Some have a level 1 trauma center where you're doing a lot more high energy type injuries. Others have much fewer trauma numbers. Some have a physician that specializes in pediatrics, whereas others don't. So they all look a little bit different. And so, my job is to really help the students in selecting externships that are maybe in alignment with what they might be interested in afterwards when they eventually go into practice. But in terms of the students, it's important to gather as much information as you can to make sure that you go to a place that is in alignment with what you're looking for in terms of your career goals. It's funny. The interview is usually the formality, because a program is usually going to have a general idea after 4 weeks if they like you or not.
Yeah, I agree.
Because after
100%.
4 weeks, you're going to be showing your true self, your work ethic, your interpersonal skills, how
Yep,
you behave when you're tired, and how you behave when you're well rested, right?
for
So
sure.
anyone can put on a good show for 15 minutes or 30 minutes at an interview, but how you function over that month usually pays off much more than a short interview.
Yeah, I think that's interesting to kind of dive into a little bit there because I have students that rotate through with me, and 4 weeks is enough that, they start to feel a little comfortable, right? It's
Hmm.
hard to maintain that attending student relationship, because I'm a little more laid back. I kind of don't, ask too many hard questions. It's more of kind of tries to be more of a fun rotation. But I think some students fall into the trap of becoming a little bit too comfortable and maybe say some things they wish that they hadn't. Because I completely agree with you that by the end of 4 weeks, back when I was in residency in Pittsburgh, we would have 4 students per month rotate through. And it didn't take long to figure out who we liked and who we didn't like. And basically, we kind of threw all academics out the window. If you're showing up here, then you've met whatever requirement or standards, or you're, a certain quality of student. So at that point, I'm judging them based on social, how do they interact with the residents? Do they show up to the
Right.
social events? Do they come to the labs? Do they show up early? I think students focus so much on academics that they don't necessarily realize that there are very, very simple things that they can do to make themselves stand out. On
100%
time is
agree.
late. You hear that and it sounds okay, well, whatever. What's he talking about? But if the student is sitting there waiting for me, then that's zero. That's no negative points, there's no positive points, it's just expected, right?
Hmm.
But if I'm sitting there waiting for the student, I'm angry. And number two, I'm not waiting for you. I won't be there. You'll be chasing me through the hospital.
Right. And there's simple things that you can do that can make yourself stand out. And these are really simple things. It's caring for the patients as if they're your own. It's volunteering for that 5 or 6 p.m. case when you're tired. It's
Hmm.
volunteering for that Saturday morning clinic. Those are the things that really do set you apart from your peers. And it's not so much about memorizing every classification system and reciting all this minutia that we're going to probably teach some of you in this trivia part of our podcast.
Yeah.
Um, but it's really those those non-measurable skills that are just so, if not more important than a GPA or a static number like a GPA or a class rank. Um, so yeah,
Another thing I
those pay off
find
much more.
Another thing I find interesting is that there are good ways and bad ways to not know the answer to a question. There are going to be questions that you don't know the answer to, and that's okay. But staring at me after I ask you a question in blank silence is not the not the right way to handle it. And so, learning how to not know something may be just as important as knowing something. I would actually start to get annoyed with people who knew everything. Like, okay, this
Mhm.
guy's a know-it-all. I don't like this guy. Um, but knowing how to say that you don't know something, and then showing up the next day and saying, "Hey, you asked me that question. I didn't know, but now I know because I looked it up, and here's
Right.
the answer." And thanks for teaching me that because I didn't know that.
Yeah,
It's
and
very
don't look it up
simple.
on Wikipedia.
Yeah,
We
try
get some
not
of
to.
those.
Try not to. So the match process, we always hear, the match favors the student, right? The match process favors the student. What does that mean?
um, so the first thing that I'll mention is that there are enough residency positions for every graduating student. So, every student that's eligible for the match can be placed in a residency position this year, which is great. I mean, there have been years prior where it was mismatched, where there was too many students for residency positions, which created a big problem. So that's been corrected. So that's certainly the good news. But in terms of the match favoring the student, so each student has the opportunity to rank as many programs really as they want. Their application fee allows them to rank, I believe, 12 programs, but you can pay more and rank more programs, right? So essentially, when it says it's favoring the student, it will default to what your first selection is. And if you're, let's say you're ranking UPMC, who I think you said had 4 residents, right?
We had 4 students per month. At the time, we had 6 residents per
Per
year.
year? Okay.
Yeah.
So as long as you're ranked either 1 through 6 at UPMC, as long as you rank them 1 and they rank you 5, you're still going to be matching with UPMC, and then your match is over, right?
Mhm.
So and that goes for, let's say you're ranked 7 at UPMC, so you'll then drop to your second then you'll drop to your second uh, program that you're ranking, and as long as you're in the top whatever amount of positions that they offer, you'll then match with your second selection, and so on and so forth, right? So it's really advantageous for the students to rank as many programs as you feel comfortable matching with, right? I always
Mhm.
say this: you need to ask yourself the question: would you rather sit out a year and re-enter the match next year, or match with a specific program? And if your
Sure.
answer is to sit out a year, then I would say maybe don't rank them.
Mhm.
But if you don't want to sit out a year, again, it's in your best interest to rank as many programs as you would feel comfortable matching with.
Because that's a binding contract. When you enter into that match process, I don't know that people understand that's a binding contract.
Yeah, you
So,
you can't withdraw from that and then say, you know what, let me try something else.
right.
This isn't really a good fit for me. So yeah, you really should think hard about what programs you want to rank, but you also need to think about, if I don't match, right? There are a few stages of the match, and we can go into detail about that. But if you end up not matching, then your only other option is to wait a year and re-enter it the following year, which definitely puts you at a disadvantage.
Sure. So
Yeah,
when I was rotating through programs, and so my wife, just for clarity's sake, my wife and I met in school. We're both podiatrists, and so we were going through that process not only as one person trying to match at a program, but as a couple trying to match at a program, and that
yeah,
can turn some programs off, right? If they think that you're a package deal, right? They love her and they think I'm not so great, right? Which is probably the case. Then that's going to complicate things a little bit. And so we rotated through, and we had a difficult decision to make of, do we try to get the same program? Do we try to get programs that are near each other in the same city, whatever it may be? But after residency interviews, they came to us and they said, they wouldn't tell us who. They said, one of you is ranked 4 and one of you is ranked 7, right? And they take 6, right? So good news, bad news, right?
yes,
Great news, you're not ranked 28th and 50th, but you're not guaranteed a spot. And so what happened was that one of my close friends from school called me and said, "Hey, I'm ranked in the top 6 at UPMC." But she was torn. I don't know whether to go to UPMC or to a program in Florida. And I said, well, there's a conflict of interest here, right? If I tell you one thing that's obviously going to benefit me, so I can't tell you, that's a conflict of interest. You just have to make the best decision for you. I said, think about it. Here are the pros and cons. She called me back and said, hey, I'm going to Florida. And this was well before match. And so we kind of knew ahead of time, okay, well, that puts me into the top 6. We don't
right,
necessarily have to worry about it, but it's very nerve wracking. There was no couples
sure,
match back then. So we each had to kind of earn the spot, I suppose, which there's some validity to. I couldn't just keep riding on her coattails like I do these days. Uh, which anybody who knows us knows that to be the case. So it's very interesting because there are lots of couples, and subsequent to us, even at UPMC, we'd get lots of couples rotating through,
hmm,
and it's a bit of a roll of the dice. Is that couple going to stay together? Are they married? Are they engaged? Are they just dating? Are they, there's a lot of stuff that goes into this whole match process. So that was my memory of match, trying to figure out, okay, am I going to end up in the top 6 or am I not? Or where am I going to go if she's in the top 6, but I'm not? We had both been offered another program as that took 2 spots, and we could have guaranteed ourselves there. And we thought,
right.
this is better training. We'll figure it out. We rolled the dice, and it worked out. But it's a very nerve wracking process for students in that. So
Yeah.
I think having someone like you on their side to kind of walk them through that process is very helpful.
Yeah, and what I'll tell people too is, if it doesn't work out for you, in terms of, let's say you ended up not matching there and going somewhere else, I always say, residency is for a finite amount of time. So there is an ending. This is not forever. And quite honestly, you're going to be so busy with your training, with everything else going on in your life that, it's not the end of the world. If it's not ideal, but it's certainly something you can work through. I mean, my residency, my third year of residency, I traveled almost 6 months out of the year. So I was gone half the year in Champaign-Urbana, in Marshfield, Wisconsin, and Dixon, Illinois, places that were outside of Chicago, far enough that I stayed there in a apartment.
Yeah.
And it was tough. I mean, I had a newborn at the time. It was stressful. We had no money. But it's like anything else. Memories tend to blossom and grow over time, and those did too. And
Yeah.
again, it was for a very finite amount of time. So I think you can deal with it. It's not ideal, but it's definitely something you can probably work through.
And that's what we decided. We decided that the training was worth rolling the dice and trying to see if, we could
Yeah.
make it work. And if not, then we'll figure it out otherwise, because you don't get those 3 years back. If you end up
No.
sacrificing your training to do some, oh, well, this one is close to my boyfriend, or this one is close to home, which is fun. There's great reasons to select whatever residency you select. But not necessarily at the sacrifice of missing out on great training, because those 3 years are formative, I think.
Yeah, they will definitely impact the trajectory of your career and your earning potential and really all aspects of your career path. So I couldn't agree more with that.
So let's say a student has their match list. Match day comes and they scramble, is what we call it. They don't have a program. Let's kind of put their minds at ease and let them know that process. What happens then?
Yeah. So there's really not a scramble anymore.
Okay.
So what we
I'm
have
old. I'm too old
now,
now.
yeah, what we have now is we have the first match. So it's a bit of a complicated process, and I wish I could. For those of you listening and not watching, we can post in the notes the process itself. But everyone finds out on the same day whether or not they matched. Not where you matched, but if you match. So if you don't match, then you enter what's called the match phase 2 or MP2 process. It's not a scramble. It's basically a reapplication, re-interview, and you're redesignating programs for the match. So there's a second match that's actually run. So that takes place the following week. So what happens is on the Friday of match day, at that point, then we find out where everyone matches. So if you still go unmatched at that point, then it is published nationally what programs still have positions available. And then the students then have the opportunity to then enter what we would call the scramble, where you're in overdrive trying to contact programs, network as fast as you can, and get students positioned into or placed into positions. So
Yeah,
that's
I
really
mean
the
that
process. Um,
that's a
so
much better way to do it.
yeah, it is. It is. And it used to be you find out Monday or Tuesday if you match, and then you got 2 or 3 days to scramble before match day, which was usually on a Friday. So it's a little bit more organized. It does allow for programs too. It gives them an advantage because they can re-interview or interview for the first time new candidates that apply, as opposed to just taking them on a whim or just to fill a position or to maybe just go based on somebody vouching for a student. So it gives them a little bit more time to do their homework and make sure, again, that a candidate is going to be compatible with their program. So it really benefits both sides.
I think that makes a whole lot of sense. I think that's
Yeah.
great that they made that change. So we're going to
Yeah, I
change
agree.
gears a little bit here. We're going to dive into what we call debate mate. So Leland and I, we're friends, but we're going to take the gloves off here and we're going to throw down and we are going to debate. What are we going to debate? Well, we're going to spin the wheel of destiny. When we spin the wheel of destiny, we're going to find out which topic we're going to debate today. Leland, you
The
ready for this?
anticipation is building over here.
All right, so we got a couple things on there. We're going to go ahead and spin the wheel and find out what we are going to debate today. Flag screw. All right, we've got Lapidus versus MIS head procedure. Lapidus versus MIS head procedure.
That's a hot topic.
It is. It seems to be invading our world, right? Whether we want it to or not. Lots of cases floating around out there with information about the latest and greatest way to fix anything, right? A lot of that is industry driven, if we're being completely honest, right? Because originally, when Lapidus described his procedure, we did not have jigs, we did not have the latest and greatest headless compression screws, we didn't have anatomic plates, we didn't have all of these things, and so some of the modifications with time are industry driven, if we're being completely honest. But let's dive into it.
Yeah, I'm gonna pay homage to Dr. Noman Siddiqui, show class of 2008, and take on the MIS head procedures. Hopefully, I'll do it justice. All right,
convince me. Why should I do an MIS head procedure?
All right. Well, let's kick this off here. And MIS. So let's define what that is first for those that aren't familiar. So I think you can, some would call it a minimal incision surgery. Some might call it a percutaneous bunionectomy. But really what we're talking about is performing the surgery through a very small incision without doing any major dissection, right? So that's essentially what falls under the umbrella term of MIS. And we can talk a little bit more about MIS because that certainly can be extrapolated well beyond just a head procedure. But if we're just talking about a head procedure, why do it there? Well, when we look at a bunion deformity, I think we have to look at it as a deformity like any other deformity in the body, whether it's of the femur, of the tibia, of the ankle, of the foot, right? It's a deformity that's defined by, your mechanical and your anatomical axis, right? So if the goal is really just to realign the mechanical axis so that first ray functions normally, we can do that at the base, we can do that at the shaft, we can do that at the head. It's just a matter of how much translation or correction do you need to obtain to be able to realign that mechanical axis and get the patient functioning better, right? So I would argue if we can do it at the base, at the shaft, at the head of the metatarsal, why not do at least the smallest amount of trauma to the patient, maintain normal motion of these joints in the midfoot, and just do it right at the head and minimize trauma to a joint that doesn't need to be sacrificed. So let's kick it off with that.
All right, I see where you're coming from. Now, I completely agree that MIS is very reasonable. If you have less tissue insult, right, that makes more sense. So if we used to fillet open everything, and by this came before our time, they're making a huge whack into everything and filleting it open and looking at the anatomy and trying to put it all back together. We found over time that compromises a lot of the vasculature and the healing. And that's not in the best interest of the patient. It may be in the best interest of the surgeon because you're getting good visualization. You're ensuring that your screws and your plates are in optimal alignment, but it may not be in the best interest of the patient. So I think that we can agree that MIS has its merits and is very reasonable. From my standpoint, a head procedure just does not make any sense. So we know that usually the etiology of deformity for a bunion is back at the base. When we look at a bunion deformity, it commonly has an atavistic cuneiform, which for those who don't know is the angulation of the medial cuneiform sending the first ray medially. Whether or not there's hypermobility, that may contribute to things. But Paul Lapidus described a fusion of the first TMT many, many, many years ago. And I bet Paul Lapidus was thinking at the time, he was going around high-fiving his buddies and saying, hey, I figured it out for you guys. You guys were doing it this way. High five. I figured out where the cora is, the center of rotation and angulation. I figured out where the deformity originates, and we're going to solve this problem at the core. We're going to solve the problem from where the deformity originates. So doing a base procedure, a Lapidus procedure, is going to take out that wedge. It's hard to describe with words. We're going to take out that wedge. We're going to translate the entire first ray, and we're going to fixate it there so that corrects the intermetatarsal angle and solves that problem once and for all. My issue with MIS head procedures is, number one, we're not correcting the etiology of deformity. We're hiding the bunion. We're going out to the head. We're making it so that the patient can't see that it's there. but it's not gone. They can still get increased translation of the first metatarsal. They can still get recurrence of the bunion deformity. Number two, as we make that osteotomy shift to the first metatarsal head, I've seen a lot of people, because of the angulation of the first metatarsal, when they make their cut, they're translating that first metatarsal head. They're effectively lengthening the first metatarsal and jamming the first metatarsal phalangeal joint. So I see lots of x-rays where they've translated that first metatarsal and the joint is now compacted. They're going to develop hallux limitus with time, right? So to me, it makes way more sense to fix the etiology of deformity, not cause them to impact the first metatarsal phalangeal joint and lead to hallux limitus and further deformity down the road. What say you?
Sure. So if we go by the definitions that I learned, and I learned deformity through working with one of my mentors, Dr. Rodriguez. I learned deformity working at going to the Baltimore Limb Deformity course. And when we mapped out deformities, and whether it's again of the thigh, knee, tibia, lower foot, we would draw the axis of two positions, and where they intersect is where we would call the apex of the deformity, right? And so if we map out a bunion on an AP view of the foot, which a lot of us measure IM angles or the first, second intermetatarsal angle on an AP view of a weight-bearing part of the foot, those actually don't intersect at the first TMT joint, but they really intersect more proximally into the mid-tarsal joint. So is that the chora? Is the chora at the TMT joint? Are there multiple choras, right? So I really think defining where the chora is can be somewhat elusive, right? I don't know if that's clearly defined. So again, I would say whether or not you correct it at the base or do a scarf at the shaft or do it at the head, you might not be correcting it at the chora at any of these locations. So to get more proper functional alignment, you do have to translate more at the head, right? Because you have to do a bigger shift because you're further from the chora, but you can still maintain functional alignment. And the most important thing is, we don't treat the X-ray, we treat the patient, and the patient's going to be happy because they're going to be weight bearing more quickly. They're going to be having less swelling, less pain, and improved functionality. And in regard to creating hallux limitus, similar to a Lapidus or to our first TMT fusion, there's certainly a learning curve with any of these procedures. And I think if you do enough and you go to cadaveric labs and you go to, train with people that are, experts in that domain, I think you can understand how to do more of a triplane correction at the head where you're rotating it in the frontal plane, you can translate in the sagittal plane, and certainly translate it in the transverse plane, and really get a good alignment. We haven't talked about Aikens yet with either of these as well too, but when you listen to leaders in the field that are speaking on MIS, I think when we did our training, we kind of heard the word cheater Aiken used a lot, where if the toe's not straight enough, you just pop in a cheater Aiken, but doing an Aiken is actually correcting another deformity that is going to hopefully minimize the risk of getting recurrent hallux valgus deformity postoperatively. So let me hand it back to you.
I would argue that we don't need to do an Aiken. I never do an Aiken. And so what I would say is, if you are fully correcting the deformity, if you are taking this deformity and aligning it back into where it should be, into rectus alignment, you should not need to do an Aiken. Unless there is an actual curvature of the proximal phalanx, which I don't know that I've ever seen, maybe rarely. The curvature of the proximal phalanx, bring it back with an Aiken. But otherwise, we're just, like you said, it's a cheater Aiken. I did my deformity correction. It wasn't good enough, and now I'm having to do a bailout procedure where I'm coming in and saying, well, that didn't really take care of it. Let me go ahead and do this. And okay, the toe is going to look nice and straight, and we're going to trick the patient into thinking, hey, look how straight everything is. So in my mind, you don't need an Aiken.
Yeah, let me ask you, what's your thoughts on a lateral release?
I typically don't do a lateral release. I typically find that I can translate the deformity enough without doing a lateral release. What are your thoughts?
Yeah, same. I've kind of moved away from doing that routinely, I think, in my first number of years in practice, to really getting away from doing that as well, too. So, yeah, unless I'm really getting difficulty relocating that congruous first MP joint, I'm really not doing many lateral releases anymore. But yeah, I mean, going back to it, some of the post-op recoveries that I've been able to see in our patients have really been surprising, because I agree, when I first trained, even for just a standard Austin, I would probably make about a 6 centimeter incision at least, and do a full stripping and dissection of the first metatarsal head, which we know, compromises vascularity to the metatarsal and slows healing, increases inflammation and pain postoperatively, et cetera. Really being able to see them progress through those different stages of recovery just by doing a percutaneous or an MIS approach has really been a game changer in terms of the recovery. So, yeah, speak to that in terms of doing your Lapidus. What's your recovery look like?
I find myself not being able to yell at you. You're too nice. I need to get in with somebody who's very defensive, and I'm like letting my guard down. I'm like, yeah, those are good points. Yeah, like that makes a whole lot of. Wait, hold on. I got to argue. All right, so I don't know. What were you saying? I was just thinking about how nice you are.
No. I mean, I can't help myself.
Early weight bearing. Yeah. So, I mean, the weight bearing protocol. So, I mean, typically what I do is an MIS Lapidus, and we'll get to that hopefully here in a little bit. And so, in my mind, that kind of encompasses best of both worlds. We're fixing the etiology of deformity, and we're doing it via an MIS approach, not compromising the vascularity and letting the patient walk on it a little sooner. Obviously, the merits of an MIS approach from a head procedure and letting them early weight bear are very reasonable. It makes me very nervous when they have the only thing holding these two things together are these two elongated beveled screws, and there's no bony apposition. Does it heal? Yeah, I've seen it heal. That doesn't make it right. That doesn't, the body healing, the body putting these two bones, the poor body doesn't know any different. It's just trying to, okay, well, I guess I got to put this bone back together. Don't blame the bone, but, letting people walk on that early, I think, is something that sounds great. And I have seen these turn to a catastrophe. I've seen them go in the wrong direction. You will not see that online. You will not see people post the catastrophe. Hey, look at this MIS bunion I did. It went horrible. Let me show you. Take a look at this. Right? You're not going to see it.
You can definitely say that about Lapidus too. There's
Absolutely.
a fair share of train wrecks. But in terms of the X-rays, I think that's probably the number one reason that turns surgeons off from doing this, is that it just looks like a funky looking X-ray when you translate that head 100% of the shaft of the metatarsal, and that's hard to get over. With the jigs now, with some of the instrumentation, you can really dial in how far you want to push that head over, and you just have to appreciate the fundamentals of deformity correction and mechanical axis realignment, and that's what you're trying to achieve to improve function. And again, the X-rays are not going to look like what you're used to looking at, but again, we're not treating the X-ray, you're treating the patient. The patients are going to be happy. Satisfaction studies will corroborate that as well too. So I think at the end of the day, that's what we're trying to achieve, is a happy patient with a good outcome.
Yeah, I can agree with that. Now, if we could just get everyone doing the MIS head procedure to just scoot back a little bit right into that midfoot and do the same thing. Just do your little MIS and do your little translation. You can even use your little jigs. I don't like jigs. I yearn for a day where surgeons don't need jigs to do surgery. So someday we'll get there.
Good use of the word yearn, by the way. I don't use that enough in my
I yearn for a day where surgeons don't use jigs anymore. So, I mean, if you just stick the MIS burr into the first TMT, you take off the wedge, you translate, you do your correction. I throw a couple crossing screws across it. It's very reasonable. So, who do you guys think won debate mate? Leave your comments at the YouTube page and let us know which side you're on. And
so let me ask you a question though, just on the topic. So, yeah. How much do you, and I'm, and you and I are both far enough in our career that I think we're comfortable in our decision-making and recommendations for patients. And really, if a patient doesn't feel comfortable with what I'm recommending or what I feel comfortable doing, I will definitely recommend a second opinion for them. But industry does a phenomenal job marketing to the patient, probably
Too
more
good.
so than ever through social media campaigns, through all different types of media. So it's an interesting age where a patient will come into the office asking for a very particular procedure to be done before they even know anything about their particular problem. So,
Yeah.
tell me about that in your experience. Are you having patients come in asking for a brand name procedure?
Sometimes, and it just takes a simple explanation to say, that's fancy marketing, and don't believe everything you see on TV. How many people go to their doctor and ask for that new, RA medicine that they saw in the commercial? Like, it's
Right,
all just marketing, and it's all trying to put that into your head. But at the end of the day, that doesn't necessarily mean that's what's best for the patient,
right.
right?
What
And
what makes
so,
me nervous though, as a surgeon though, is if they come in and ask for it, and then I recommend something different, and we do that, and they're not happy with their outcome, what's going to be the consequence then? And that makes me a little bit nervous.
yeah, I agree with you. Luckily, I'm busy enough. I'm overflowing with patients. I cannot see all of my patients that I need to be able to see. And so if they come in and they are hell bent on this procedure, I say, I know someone who will do that for you. And if you're coming
Sure.
in requesting the procedure, that's a red flag to me. This is
100%.
not a patient I want to operate on. They think they know better than the doctor. Nope.
Yeah,
I'll
that's a
send you
that's an
somewhere
unhealthy
that,
relationship. That's a
yeah,
bad
that's
start.
not a good start.
Yeah. Yeah. So
So I
just
think
just
that's,
kind of a word of caution, especially for the new providers that I think are more trying to be people pleasers, and these are your first patients, and you really want to just do everything you can to make them happy. You can definitely get yourself in trouble by doing things that might not be in their best interest. So remember, you're there to be their doctor, not their friend.
yeah. So to wrap that section up, obviously we're kind of doing this in jest, kind of having fun with each other. It all depends on the surgeon, right? There might be a procedure that is best for you to perform, and there might be a procedure that's best for me to perform. I feel comfortable with a Lapidus. Maybe you feel comfortable with an MIS head procedure. At the end of the day, if the patient is walking pain free and is happy, we have both accomplished our goal, regardless of how we get there. You went around this way and I went around the other way, but we both got to the same goal. So I don't want people listening to think that we're, actually bashing each other or bashing these procedures, right? So I do have some issues with some of these things. Just, I don't know that people have sometimes thought all of this stuff through. They just start doing it. And the downstream complications that may arise, or sometimes you don't know what they are until you do it and then wait 5 years, both with, Lapidus and
Yeah.
head procedure, any procedure is possible. So
Sure. Absolutely. And I think, making sure you do your homework, you do your work in the lab, in your cadaveric lab, call your local reps. They'll be happy to bring you into their lab to work with people more experienced than you to train on these different procedures. You can even bring people into the OR with you to go through some of those first few cases because no case goes perfectly by the surgical technique guide, right? There's
right.
always nuances in the OR, and those are the things that you have to be prepared for.
You're telling me sawbones aren't like a real patient?
Well, no, no,
You make
definitely
an
not.
osteotomy and it falls on the floor. If that happens to your patient, we got some problems.
5-second rule.
Put it back. Put it back. Just to spin off on the case that we had just been talking about, I think this encompasses maybe the best of both worlds. For those watching, they can look at the x-rays. For those listening, you may have to go back and watch or envision what we're going to talk about through here. I've named it in the name of industry. I have named this the Lapidus. Okay. That's trademarked. Not really, but it should be. The Lapidus is my procedure for doing a minimally invasive Lapidus. So you use this burr system, and this is mostly educational. I'm joking around, but this is educational as well. So this is me in the OR, and those are the portals for exposing the first TMT. I do a medial and then a dorsal lateral approach. The reason you do two portals, well, for two reasons. Number one, it allows you to access all components of the joint. Number two, you want to flush out the cartilage. So if you do two portals, you resect the cartilage, you're happy with what it looks like on x-ray, you can distract the first TMT, flush through one, and cartilage comes out the other. You can also inject bone graft into both of those areas. So here's a relatively minor bunion deformity of a young girl that came in with the atavistic cuneiform, first intermetatarsal angle of 14 degrees. And then I kind of translate it a little bit and get it back into proper alignment. You always do. Talk about cheater. I think shaving the first metatarsal head when you do a Lapidus should be called a cheater silver or something, because I always find that when I do this, I always have to go and shave the first metatarsal head anyways. So, but then you've translated, you've improved the first intermetatarsal angle, you use some crossing 4.0 headless compression screws, and then there's a snap off pin there. So one of the most important parts of the procedure is to ensure that you don't elevate the first metatarsal. I think that's common to do, because when you do your osteotomy, whether it be with an MIS burr or an open blade, you're more tending to take a larger section dorsally, because that's what you're looking at, and a much smaller section plantarly. And if you can picture a wedge with a larger portion taken dorsally than plantarly, when you compress that, it's going to elevate the first metatarsal. You want to make sure that you're not causing metatarsus primathilevatus, which is a fancy term for elevating the first metatarsal. You don't want to cause a new deformity.
And it's a much deeper joint than I think a lot of people appreciate. I think it's like 3.2 centimeters deep.
Yeah, 3.6, something like that.
Yeah. So it's if you're going straight from dorsal, it's sometimes leaving a plantar ledge inadvertently can cause the first metatarsal also to elevate. So
very, very common. I see it frequently. So
yep.
That's a case that kind of we talk through there, and the merits of MIS and the merits of doing a Lapidus, and obviously the merits of MIS head procedures are there as well, especially in the people who do it a lot, right? Just like if you do total ankles, you do anything. I do lots of trauma. I can fix an ankle fracture blindfolded. I'm not saying that because I'm fancy. I'm just saying I do it so often that I don't get many curveballs. I know what I'm doing. I know how to fixate, certain things based on the morphology of the fracture. So if you get good at something, then just get good at it.
I liked your Instagram post about, I forgot what it was, but it was basically measuring your power index for certain.
Oh yeah. Yeah.
You know what I'm talking about? There was a post.
If surgery was a video game, was a video game, I said, if surgery is a video game, I'm a 99 overall, which is not true.
That was a good post. That was awesome.
Yeah. Some people got it, because hands, right? Wide receiver hands, surgeon hands, agility. I'm not very agile, but speed, right? Speed correlates with football and speed in the OR. So yeah, for sure. Fun. Leland, I'm sorry I had to beat you up there on the debate.
Yeah, no.
And make you look silly. So
all in good fun. It was tough to take the MIS side, because quite honestly, most of my Lapidus training was done with one of your colleagues, Dr. Sean Grambart, who I could be wrong, but I think he's a product of Seattle training.
Yep.
Where they're big on Lapidus. So it broke my heart a little bit, but all in good fun.
All right. Well, maybe you'll get the side that you are favoring next time.
No, it's
spin the wheel of destiny next time, and maybe it'll be in your favor.
Hopefully.
Well, thanks for joining us on another episode of Pod Patrol. Stick with us as we continue to invite on esteemed colleagues and guests and experts in their field. For those listening, you can find us on Spotify or Apple Podcasts. And for those who want to visualize the podcast, which is part of the intention of the podcast, you can view us on YouTube. Like and subscribe, like and subscribe, like and subscribe. Is anyone else tired of hearing that? Like and subscribe.
That's right. And again, we appreciate you guys tuning in. If you have any questions or want to reach out to either of us, feel free to comment below, either on the YouTube channel or on any of the podcasts, or reach out to either of us via email if you're looking to reach out, collaborate, or have any questions for either of us.
And check out Leland's website, higherlearninghub.com, for more good questions and insightful commentary in our field. So until next time, I'm Dr. Jeff Dikis.
And Dr. Leland Jaffe. We'll see you next time.